Well, good afternoon, everybody. Thank you for coming to this Dean's Lecture. I know most people in the room, but for those I don't, I'm Mike Clagg, and I'm Dean of the school. And we have these lectures to celebrate when someone gets appointed or promoted to the rank of professor at our school. And I always say that it's not easy to get appointed to the faculty of our university, but it's especially difficult to make it to the rank of professor. It's a high bar, and it's a decision that's operationalized through the A&P committee and the advisory board of the school, but it's really based on data that's obtained from all over the world from the peers of the nominees who provide their evaluation of the candidate and give us the information of whether the person should be raised to the rank of professor. And in Shruti Mehta's case, it was a very easy decision. Just got people all over the world think highly of her, and my job is to introduce her. This is also somewhat ironic because I always end up introducing the candidate to people who know them much better than I do, but I'm gonna try a little bit. So Shruti came to us came on the faculty in 2003 in the Department of Epi, and has worked on a number of areas, but especially marginalized, hard to reach populations, and trying to understand the epidemiology, natural and treated history of HIV, hepatitis C, and HIV/HCV co-infection. She works with injection drug users and men who have sex with men, as well as their partners here in Baltimore and in India, particularly in Chennai. She's the PI of two large cohort studies, the ALIVE study in Baltimore, which was started many years ago by David Celentano, and the Chennai HIV, hepatitis C virus, and liver disease, the Cheers cohort. Did you say Cheers? Yeah, Cheers. Okay, in Chennai. And both studies are prospective studies that follow injection drug users for a variety of infections and co-infections. She's worked hard to understand the use of surrogate markers to stage liver disease in populations where it's just not feasible to do what we would do clinically, and that is liver biopsies. She's worked to identify and overcome barriers to care and treatment of HIV and Hep C infection among injection drug users and other marginalized populations. She's now the co-PI of a new study to test the efficacy of integrated care clinics in improving HIV testing and treatment outcomes among injection drug users throughout India. And we talked a little bit about that earlier. It's 27 cities, I think. It's a large number of cities. Actually, it's 15, it says right here. It's a cluster randomized trial. So she's published over 160 papers, lots of book chapters and presentations. She was appointed to professor in the last academic year, and her letters indicated she's a terrific mentor to many of our doctoral and master's students. She serves as director of the infectious disease track in the Department of Epidemiology. She's co-director of the Johns Hopkins HIV Epi and Prevention Sciences Training Program, and co-director of the Clinical Core and the Substance Abuse Working Group of CFAR here, the Johns Hopkins Center for AIDS Research. And it's really nice, I meant to say, to see so many folks from HIV, or from ID and from the School of Medicine here. I see Dave Thomas and Dick Chasen, among others, so thanks for coming. So here, I guess this is one area where people might not know about this part of your background, about your undergraduate major, right? So we could do, if Stephen Ganji was doing this, he would do he would have a response thing. So I'll just say, I'll cut to the chase and say that she has a BA from Northwestern in art theory and practice. She received her MPH here at the school and her PhD. So please join me in welcoming and celebrating Shruti Mehta.
Thank you for that kind introduction. Thank you all for coming. It's a real privilege to be doing this today. So I'm going to tell you a story. I'm going to tell you a story about two epidemics, how they've influenced my own journey, and ask the question, are we really at the beginning of the end? So since their discovery, hepatitis C and HIV have in some ways been on parallel courses, and they have many things in common. So both are RNA viruses, and they have overlapping routes of transmission. But there are some important differences. So hepatitis C has a higher replication rate, a higher mutation rate, and it can survive much longer outside the human host, making it about 10 times more transmissible than HIV. Both infections can remain silent for years, but once inside the human host, HIV progresses much more rapidly and universally causes chronic disease versus hepatitis C, which causes chronic disease about 85% of the time, with an even smaller proportion developing severe complications. These differences are why the global prevalence of hepatitis C is actually 4 times that of HIV, but we still see more deaths globally due to HIV. There's also been a difference in terms of the response to both viruses, both from governments, from payers, and from the public, with HIV eliciting a much more significant response on all fronts. But that robust response to HIV has actually also benefited hepatitis C in some indirect ways. In particular, in the early years of the epidemics, once it was recognized how the viruses were being transmitted, prevention strategies put in place for HIV benefited both infections, right? So we saw dramatic declines in incidence in both HIV and hepatitis C in response to these prevention strategies. But it's been with treatment that the conversation has really started to change, and we've started to hear things like elimination, eradication, and the beginning of the end. From the popular press to the scientific literature, all of these words are being used. So what about treatment made this happen? So the first big moment, of course, for HIV was in 1996 with the discovery of protease inhibitors. And drug development after that point proceeded fairly rapidly, right? Many drugs were licensed. But it wasn't until 2011 with a landmark study that demonstrated that treatment of an infected individual could prevent onward transmission to an uninfected partner that our thinking really started to change. And the idea of treatment as prevention really became realized. Science magazine actually called this the breakthrough of the year in 2011. Combined with modeling exercises that suggested that universal screening and immediate treatment of HIV could actually change the course of the epidemic, taglines started to change, things like getting to zero, an AIDS-free generation, and the beginning of the end of AIDS. The path was a little bit slower for hepatitis C, right? So the first drugs actually became available even earlier and around the same time, but these were nowhere near the coup that protease inhibitors were, and drug development really stalled for about a decade. 2011 is actually often heralded as the 1996 for hepatitis C because this is when the first protease inhibitors were discovered. The game changer drugs really came afterwards in 2013, and now we're seeing drug development proceed at a fairly rapid pace. But we don't have to wait 10 years for conversations about eradication of hepatitis C to start. They're already here. Because with hepatitis C, we have the ability to cure. And not only do we have the ability to cure, but with short duration medication. So these new drugs have taken us from efficacy of 50%, where we were for about a decade, to more than 90%. The duration of treatment has moved from a year to just 12 weeks. And we've gone from interferon injections that are toxic and cumbersome to fixed dose combinations that can be taken 1 time a day. Modeling exercises piggybacking on HIV suggest that rapid diagnosis and treatment of hepatitis C have the potential to reduce the burden to near negligible in the United States and other settings. So despite these different trajectories of drug development, we find ourselves at a similar place for both infections, asking really similar questions. But where are we really, right? Where are we with respect to these modeling projections? How many people have access? So with HIV, with things like development of generic antiretrovirals, programs like PEPFAR and the Global Fund, we've seen access improve dramatically across the world. But still today, fewer than 34% of infected individuals who need treatment in low and middle income countries actually are on it. For hepatitis C, we've seen conversations again about generic antivirals starting already. But the picture for treatment is a little bit more stark, with fewer than 5 or 10% actually having access to medications globally. Beyond this, there's disproportionate burden by groups that seems to be growing, right? So across the world, HIV incidence seems to be declining in most countries. But in some risk groups, it's not the case, right? So among men who have sex with men, young women in Southern Africa, and people who inject drugs, in many parts of the world, incidence is actually still increasing. As you can see from this map, of the estimated 11 to 21 million injection drug users, upwards of 6 million may be infected with HIV, and up to 15 million are estimated to be infected with hepatitis C. Hepatitis C is always disproportionately infected injection drug using populations, with up to 80% being infected. So if we want to think really about any sort of global elimination strategy, we're going to have to address all of these groups, including injection drug users. So there are a number of challenges. If we want to think about elimination, control, eradication, what have you, number of challenges, but this is the one that I'm going to focus on here today, which is targeting where the burden is, even if that's where it's hardest to reach. And that's where most of my work has focused, on injection drug using populations. So as I prepared this, as I think many of us probably do, I found myself kind of thinking about how I got here and what the path was, how I ended up working with injection drug users. And when I came here many years ago as a student, I, like many other idealistic students, came here and kind of wanted to work on HIV globally. I had a real interest in HIV in India and was focused really on heterosexual populations. Drug use was pretty far from my mind, but I think coming here and seeing the work that was going on and basically what was happening in the communities around us, I think is what brought me to drug use. And so while it's made a career that I've spent a lot of time at posters by the bathroom at some of the big HIV meetings, because that is where we often end up. My career and my life have definitely been richer for it. So I'm going to talk about some of the challenges and opportunities to reaching this group, and I'm going to do it from the lens of two settings. And I'll start with some of the epidemiologic data from Baltimore that tells us about the challenges in accessing this population. So what do we know? First, let me actually say where I work. So I've worked in primarily two populations in Baltimore. So I've had the honor and privilege of running the ALIVE study for the past 11 years with Greg Kirk. As most of you in this room know, ALIVE was started by the visionary Frank Polk, David Vlahoff, David Celentano in the late 1980s, and has recruited more than 4,500 injection drug users to date. There are about 1,200 in active follow-up now. About 25% are HIV infected, and about 80% are hepatitis C infected. The other part of my work is in the Johns Hopkins HIV clinical cohort, which is directed by Richard Moore. And for about a decade, Mark Sulkowski and Dave Thomas have had hepatitis C-focused studies in this cohort. And through access to both of these populations, we've been able to look at issues of access in both people who are in and out of care. So now what do we know? So in the early years of the ALIVE study, it was demonstrated that drug users could actually respond to HAART just as well as other groups. There were some concerns that maybe they couldn't, but there were some delays. There were some ways in which they were falling behind, and in particular in initiation of therapy. So what we see in ALIVE is that even though the drugs became available in 1996, it wasn't until 1998, 1999 that people really started to uptake in ALIVE. And you can see across the years here that there were large numbers of individuals who just didn't initiate. And even though this number has increased over time, what we see is in recent years, people are initiating after a long delay, right? So on average, after about 6 years of being eligible. Even when they do initiate, interruption seems to be the norm rather than the exception. And you can see that here. So when we put all of this data together, and this is the most recent analysis that was published by a GTPCI fellow here, Ryan Westergaard, what you see is that our big problem today is retention, right? So in ALIVE, it seems like everyone eventually gets into care. They get on antiretroviral therapy, and they can get virally suppressed, but they just don't stay there. So we've spent a lot of time trying to understand the why, right? Why do some people get into care and not, and why in general is this group doing a little bit more poorly? And I can say that whatever outcome we look at, whether we're looking at delayed initiation, interruption, virologic failure, we kind of see the same factors pop up. We call them the usual suspects because it's the same picture every time. And they group into two categories. So the first are factors related to healthcare access. So you find, not surprisingly in some ways, that people that have better access to healthcare in general do better with HIV. The flip side of this are these other factors that I call, I think of being associated with stability. So homelessness, incarceration, unemployment, low income. Now, all of these are linked to ongoing injection drug use. And on the whole, we find that people who are actively injecting, and in particular, people who are injecting every day. So the heaviest injectors tend to do the worst, right? So they do a lot worse than people who inject less frequently and those who've stopped altogether. Given this association with drug use, we've taken some time to try and understand what the natural history of drug abuse looks like, and this cohort provides a unique opportunity to do that. So these are some data from a doctoral dissertation of one of my students, Becky Jenberg, that shows you that the population on the whole clusters into smaller groups, right? So 5 groups actually. And so of the entire sample of ALIVE, you can see that about a third seem to remain persistent injectors across their lifetime, meaning they're injecting almost at every visit. The remainder kind of classify into these other patterns of either frequent relapse or cessation at some point. And what we find is that everyone stops for at least a 6-month visit. And a large proportion even stop for 2, 3 years, maybe even 4. But even the people who stop for a long time, relapse is not uncommon, even if it's just relapse for a one month or 2-month period. When we try to link these data with outcomes to see how they do in terms of HIV and mortality, we find that on the whole, persistent injectors do a lot worse, right? They do worse when it comes to HIV, and they have the highest mortality rates. Unfortunately, mortality in this cohort has gone down substantially, particularly mortality related to HIV and overdose. But what we've seen is the flip side of that, which is increased hepatitis C-related mortality. And we've seen this in ALIVE, and we've seen this in the Hopkins HIV clinic, which is where these data are from. This is an analysis led by a medical student, and you can see here just the increased risk of liver-related outcomes over 10 years of follow-up in the Moore clinic, particularly among those who have severe disease at entry. Now, of course, treatment for hepatitis C, like HIV, can be life-saving, right? So if you look in the same analysis, the people who got treatment, and not just got treatment but got cured, there were actually no events over the same period compared to the groups that either didn't get treatment or took treatment and didn't respond. But the problem is that most people don't get treated, right? So these are some old data from the old treatment era when we were still treating with interferon and ribavirin. Toxic medication needed to be taken for a year and a lot of side effects. But still, this was a pretty captive population. So this was a group of people that were engaged in care for HIV. There was a viral hepatitis clinic on site, and cost was really no barrier because their hepatitis C care is covered under the umbrella of HIV care. And what you see is despite that, over a 7-year period, fewer than 20% were referred and fewer than 3% actually got cured of their hepatitis C. So this picture, like I said, these data are old. This picture has improved, not as much as you might think, though. It's likely that it will improve in the future, but there are still challenges because there are essentially barriers to every step of this continuum. And this is something I've spent a lot of my career thinking about. What are the challenges to getting people into treatment and getting them cured? And there are barriers at every step. So at the level of the patient, at the level of the provider, and at the level of the system, right? And these impact every step of this continuum from diagnosis to linkage to getting on treatment to achieving cure. And the new treatments are amazing, and they're going to strip away some of this, but they're not going to strip away all of it. And there's going to be a lot of barriers that remain that we're left to deal with if we really want to change the picture that I just showed you. All right, so that's a little bit of the epi data from Baltimore. I'm going to turn to India, and what I think you'll see is despite these two places being worlds away, there's an incredible number of commonalities, particularly in this risk group. So just to orient you to some of our work and how it's evolved in India. So we started our work in Chennai, in the southern state of Tamil Nadu, in collaboration with an organization called YRG Care. So YRG Care has been led since inception by Suniti Solomon, and it is really a pioneer in both HIV research, care, and education, not just in India, but really around the world. The collaboration between Johns Hopkins and YRG Care was initiated by David Celentano in the late 1990s, and many of us here have benefited from that collaboration. YRG has seen I think they've registered more than 30,000 clients since inception, and they've provided care to more than 20,000 HIV-infected patients. My work with YRG began in 2005 when Sunil Solomon initiated the YRG Center for Substance Abuse Research to provide care and conduct research among substance-using populations. So our first study was actually Sunil's doctoral dissertation, which was funded off of a small supplement, and it was essentially to create a cohort of 1,000, more than 1,000, and follow them for 3 years, modeled much after the ALIVE study. Since then, we've moved across India, and we're starting to work in different parts of India. And in part, we moved out of Chennai. We're still working in Chennai, but we moved to these other places because that's essentially where the drug use epidemic is in India. And India occupies a pretty unique position with respect to drug use because it's situated between the two largest heroin production regions in the world, right? So the Golden Triangle on the east and the Golden Crescent on the west. And so it's resulted in a pretty diverse epidemiology of drug use, right? So in the Northeast, we see these historical epidemics where drug use, HIV, and hepatitis C have been endemic for decades. But there are now newer emerging epidemics in North and Central India that are thought to be related to the opening of trafficking routes because of heroin production in Afghanistan and Pakistan. So we still do have some work in Chennai that's more focused on sort of prevalence and pathogenesis of liver disease and delivering hepatitis C treatment. But we've moved more to this large-scale study, which is more across India. It's a cluster randomized trial. I'll talk about some of the baseline data from that trial. And this is a study that I work on in collaboration with Greg Lucas from the School of Medicine, Sunil, who I already mentioned, and David Celentano. So what have we learned? Well, we started here with pretty basic epidemiology because when we started, there actually just wasn't a lot of data from most of these cities. And so as part of the cluster randomized trial, our baseline sample sampled 1,000 people in each site using a technique called respondent-driven sampling. And what we find, not surprisingly, is that the prevalence is highest in Northeast India. Right, so this is again where those historical epidemics were. But even in these newer emerging epidemics, the prevalence on the whole is lower, but you can see there are still cities with 20 and 30% prevalence. We were also able to measure incidence using a multi-assay algorithm that was developed by Oliver Leyendecker here at the School of Medicine and some of his colleagues to estimate incidence from cross-sectional data. And what you see is a bit of a contrast, right, between the prevalence and the incidence data. So we see much lower incidence in the cities that had the highest prevalence. But if you compare that to sort of north and central India, you see high incidence and in some ways exploding incidence in the center of the country. And the city in the center, Kanpur, is sort of an interesting case. When we set out to do this study, Kanpur wasn't on our list of cities because there really wasn't any data from there. But we're working in partnership with the National AIDS Control Organization, and essentially they said to us, we're hearing about drug use in Kanpur, we'd like you to work there. And for anyone who's worked in India, if NACO tells you they want you to work in Kanpur and you want to continue working in India, you work in Kanpur. So we worked in Kanpur, and we basically, I think, caught an epidemic that was just beginning, with really high prevalence already, but absolutely exploding incidence. Hepatitis C prevalence, as it is in most settings, was an order of magnitude higher, right? So, and you don't see the same you see geographic variability, but it's not necessarily that the historical epidemics have the highest prevalence. You actually see many cities, even in north and central India, that have 40, 50, 60% prevalence. About 1 in 10 had both hepatitis C and HIV, and then of those who had HIV, 72% were co-infected with hepatitis C, again reinforcing that if you want to deal with HIV in this population, you're also going to have to deal with hepatitis C. So high burden of infection, but suboptimal access to care, right? So among the near 3,000 HIV-infected individuals across these 15 cities, 41% reported at the time of our study that they had been previously diagnosed, so they were aware of their status. 14% had ever initiated therapy, and only 11% had suppressed viral load at the time of our sample. If HIV care was bad, then hepatitis C care was almost non-existent. So fewer than 5% were aware of their status at the time that we took the sample, and many have remarked that this actually looks a little bit more like a care cliff than a care continuum. Even more striking than this is that of those who weren't aware of their status, the majority had never been tested, right? So only 7% reported that they had ever had a hepatitis C test, and the primary reason for not being tested was never having heard of hepatitis C. So when we dig a little deeper here, like we did in Baltimore, to understand the why, we see a lot of similar factors, right? The predictors that we saw in Baltimore were the same ones we saw here in some ways. So daily drug injection was a barrier to successful engagement in both HIV and hepatitis C care. But on the flip side, there were a number of facilitators, in particular high education, and also access to other services. So if you were in drug treatment, if you were in care for TB, for hepatitis C, if you were in care for HIV or had had an HIV test, you were much more likely to be aware of your hepatitis C status. So this was cross-sectional data, so we're not able to look long-term at what the consequences of this low access are, but from our data in Chennai, we can infer, because in that study, we followed people for about 3 years. And I didn't show you the care continuum for that study, but it looked very similar to the ones that I showed you from across India. So what we see is in a time in India where antiretroviral therapy is available free of charge from the government center, right, to anyone who will go, the mortality rate among HIV-infected drug users with a CD4 less than 200 was 35 per 100 person years. This was 11 times higher than the average urban male in Chennai and 3 times higher than IDUs in Baltimore in the late 1980s, right, so when there was no therapy in the US, so absolutely unacceptable. Now, most of the mortality that we've seen, again, in our cohort, paralleling what we saw here in the early years of the epidemic, is due to HIV and overdose. But we're starting to see that shift even now, even when access to antiretroviral therapy isn't as good as we expected it to be. And so through this newer cohort, we're able to actually stage liver disease because we have a non-invasive method. We have a FibroScan machine that allows us to non-invasively stage people's liver disease. And what we see is that despite the median age of this cohort being only 39 years, more than 50% have evidence of significant fibrosis, with 28% actually having evidence of cirrhosis. We've looked preliminarily at progression in this cohort because we are following people every 6 months, and what we see is potentially rapid progression even among the group that had no disease at baseline, right? So this is just progression over 2 years, and this is preliminary data. We still need to confirm it. The thing is that the biggest driver of fibrosis and mortality in this population is hepatitis C, but there's also a confluence of other risk factors. So extremely heavy alcohol use, on average about 4 drinks a day. There is co-infection with hepatitis B, genetic predisposition to insulin resistance, and a lot of fatty liver. So all of these things are driving fibrosis in this population. One of the things that was a little bit different, in terms of what we saw here versus Baltimore, is the impact of potentially, even the most minimal level of intervention, right? So nothing I've shown you so far includes intervention, but this is just the minimal bounds of what we provide in a cohort study, right? Every 6 months, people get an HIV test, they get education, they get counseling. And what we saw in our initial cohort was the incidence was actually pretty high at baseline using the cross-sectional incidence algorithm, 3 per 100 person years. But over follow-up, very few people seroconverted. There was almost no HIV, and also a pretty low incidence of hepatitis C. And when we see, it looks like nearly the entire population stopped injecting drugs. And we went back. We didn't believe this either. Neither did the reviewers at any journal. But really. And so we went back. We did a lot of focus groups. We talked to people. And overwhelmingly, the answer we got when we said, well, how did you stop? Why did you stop? And they said, well, you told us to. It turns out, I think there's some levels of addiction issues here because of the types of drugs they're using. But it turned out that this was a naive population. None of them had been tested before they came to our study, no opiate substitution, no needle exchange. This was the first time anyone had talked to them about the consequences of their drug use, and so a pretty dramatic impact of barely any intervention, suggesting the potential for what we could do going forward. So some differences between these two settings, but also a number of common themes, right? We see across both settings suboptimal engagement in HIV and hepatitis C care, a combination of individual and structural barriers, and then an increasing burden of hepatitis C morbidity and mortality. So what do we do? So with the developments in HIV therapies, the mantra has really become seek, test, treat, and retain, right? And all of this is really a comprehensive strategy to identify individuals who are at high risk for HIV, hard to reach, and haven't been tested, get them tested, get them into care and on treatment, maintain them on ART, and retain them for the rest of their lives. The idea is that not only does this confer individual benefit for the person, but also can potentially prevent onward transmission. The paradigm is easily extendable to hepatitis C, of course, except it's a shorter path, right? So instead, we have a seek, test, cure, prevent. And each of these essentially suggests a target for intervention. And there have been a number of successful interventions among this population in the US, in India, and all parts of the world. Most have really focused on people who've been diagnosed, right? Trying to get that group sort of linked to care, on treatment, and sustained on therapy. And I've used a number of different strategies, and I've just listed a few here. So everything from education to directly observed therapy to try and improve adherence, patient navigation to help get people to their appointments, case management to deal with some of the other challenges that people face, and then peer support, right? And all of these essentially target, or they focus on, individual level barriers. There's been a little less work, to target the entire continuum, right? And these interventions tend to need to be more structural in nature. A place that we've been really interested in is integrating services, right? This idea, if you take all of the different places that someone might need to go to get different services for their HIV, for their hepatitis C, for their drug use, and instead of keeping them separate, bring them together, perhaps not only will you help people get through care and treatment, but you might also identify people that you might not previously have identified. So with that background, I thought I'd give you an example from each setting of the type of intervention that we're sort of engaged in, so you can see kind of how we're thinking moving forward. So in Baltimore, what many of us are most excited about are these new drugs for hepatitis C. But with everything new come challenges, right? They're not necessarily the magic. They are the magic bullet in some ways if you can get access. But the challenge is that because these drugs are so expensive, there are a lot of restrictions on who can actually get access through insurance. There are restrictions related to active injection drug use. There are restrictions with respect to disease stage. And so this is a project that's really focused on trying to treat that group that's not going to have access through any other sources, right, that would be likely to be turned down by insurance. This is actually a multi-site trial. You can see the cities that we're in. We're in 8 cities, and the PI is actually Alan Litwin in New York. And actually, this is not something we've been funded to do. This is a proposal that just went in a couple of days ago. But it illustrates, I think, well, the kinds of things that we're really interested in. And what we've proposed is a combination structural individual level intervention, right? So the structural intervention here is to integrate hepatitis C testing and treatment into venues where drug users are already accessing the system, right? So take methadone programs, community health centers, where people are already going. So meet them where they are, test and treat them there. So patients will be treated either, those that are already accessing these programs, but will also include referrals from other community sites, right? So people could be referred from needle exchange, for example. Now, the individual approaches will be nested within this, and this is actually where we're randomizing. So we're going to test and compare a combination of patient navigation and peer support versus directly observed therapy. And this is really focused on addressing those individual level barriers once we identify people who need treatment. Both groups will be treated with 12 weeks of all oral therapy. The primary outcome is cure at the end of therapy, but we'll also be following people for 2 years to monitor for reinfection. So again, fingers crossed, but it gives you a sense of the kinds of things we're interested in. In India, I thought I'd talk about a trial that's well underway. So this is the one that I've mentioned already that I showed some of the baseline data from. So this is, I've talked about the IDU component, but there's actually 2 parts to this trial. So there's an IDU stratum and an MSM stratum, and the intervention is essentially the same in both. It's a one-stop shop, basically all services that an IDU or an MSM would need in a single site that's tailored to that population, right, to address some of those stigma issues as well. So for the MSM sites, which is led by David Celentano, we're mostly in southern India, and for the IDU sites, you can see we're in north and central, again, in northeast India. The design is essentially an intervention that's nested within 2 cross-sectional studies, right? So the intervention will run for 2 years. The first cross-sectional sample was taken at baseline, and the second will be taken after the intervention has run for 2 years. And for each of these cross-sectional samples, we're using respondent-driven sampling, recruiting 1,000 people per city. And the control, so 22 sites are getting randomized or have been randomized. 11 receive the intervention, and 11 have the control condition, which is essentially all services available, just delivered in segregated centers. So I showed you some of the baseline data already, and I talked about how access to other services seemed to be a gateway for HIV care, right? But what I didn't show you was how few people actually had access to multiple services. So this is an analysis that's being led by a postdoctoral fellow, Kumi Smith, to look and understand the overlap of services in the absence of intervention. And essentially what you see here is a lot of missed opportunity, right? So the circles where they don't overlap is where people are only accessing one service. So you see a lot of people that are accessing just needle exchange, just opiate substitution, and not accessing any of the HIV services. So our goal is that our intervention, by putting everything in one place, really changes this picture, and then by translation, some of these downstream outcomes. So it's truly a public-private partnership. So we're actually partnered with the Indian National AIDS Control Organization, and we opted not to build new centers. We did think about that, but we're actually scaling existing centers, right? So taking a center, a drop-in center for IDUs, where they already deliver one center and building the other pieces in. So this is just an example of one of our sites in Imphal in Manipur. And so the center of our model is opiate substitution, in part because this is how we decided to build. So we picked sites that were delivering opiate substitution already and built from there. Now, opiate substitution is paid for by the Indian government, but it's delivered in different centers, right? So in some cities, it's delivered in NGOs. In other cities, it's delivered in government centers. In some cities, it actually wasn't available at all. And so we had to start from scratch. So the spirit of the model is the same in each city, but we had to tailor a little bit to the individual needs of the community. Now, because we're partnered with the government, they're actually providing all the services free of charge. So all the test kits, all the drugs, they come from them. What we're providing is additional staffing, sensitization, community outreach, and just training. So the other two core services, of course, are HIV counseling and testing and antiretroviral therapy. Now, because we're partnered with the government, we still have to have some things happen at their sites, right? So positive HIV results have to be confirmed at their sites. They're the people that are storing the antiretroviral therapy. But what we've done is incorporated peer health workers so that we minimize the visits that our clients have to make to those other sites, and so that they can receive most of their care within our ICC, right? So rapid HIV testing is done within our clinics, but then the positive results will be taken by peer health workers to the government centers to be confirmed. Antiretroviral therapy is delivered through a link model where a peer health worker takes the client for that first visit to get them started, but then picks up all of their refills at the government centers and delivers them again through our ICCs. That way the client has interactions with our doctor. The other services that we're offering, of course, are counseling. Counseling was in some ways there, but we've scaled it up. Combination of individual and group counseling, condoms, of course, STI management, needle exchange, which is both in the clinic but also done in the field, TB testing and treatment, so we're linked with the local DOTS program to test TB to at least collect specimens within our site and then link with the program for those who test positive, and then some aspects of general medical care. So there's a physician on site that can provide general care if people have a need. So this gives you a sense of what the sites look like. They look very different. You'll see from the next picture. So this is an NGO-based model, again in Imphal, Manipur. And you can see a couple of our staff members. These are our two nurses. It's our counselor, and this is the room where the doctor sees patients. These are two of our sites in North India, so in Ludhiana and Punjab and Chandigarh, and these are in government centers, and you can see a little bit of a different feel in the government center. And so this also gives you a sense of the size of our staff minus some U.S. visitors. And the gentleman in the center here, who's Krish, who's one of our Indian PIs, research manager extraordinaire, who's running around India managing all of this, truly incredibly. This also gives you a sense, so this is Ludhiana, which gives you a sense of the sort of client load at any given point in time. Ludhiana is actually one of our busiest sites. They see about 200, 250 people a day. So because of that, because of client load, because of distance, and because of danger in some cities, we actually had to scale more than one ICC. Our plan in each city was just one, right? We thought that one would be enough to reach the surrounding population, but it turned out, for example, in a city like Imphal, so Imphal sort of exists every day like Baltimore did last week. It's essentially a police state. There's curfews, there are riots, people can't go out at night, and so it's just too difficult for people to travel far, so we built up 3 ICCs. In a place like this, Chandigarh, the distance was just too much. So you can see participants are clustered in 2 parts of the city, right? And so for those of you who know India, this distance may seem short. It's not short. It could be like 2 to 3 hours to go from one part to the other, even if it's only 5 or 10 kilometers. So in some places we scaled up 2 ICCs because of that. So what about Hep C? You might be wondering. I mentioned it as an essential service. I talked about the burden. I talked about the need, but there's no hepatitis C services in our model. So in part, sustainability was really important to us because if we demonstrate this to be effective, we want it to be able to exist when we go. So we are only providing services that are paid for by the government, right? So everything that we're delivering is actually things they provide anyway, and they don't currently provide hepatitis C testing and treatment. And just because we're not providing it doesn't mean it's not on the minds of our clients and our staff, and particularly in Northeast India, where again, hepatitis C and HIV have been endemic for decades. This is their main concern. And the words on this poster in the back of our counselor's room say more than I could say. So what are our plans? This is something we're thinking about. I think first we need to get buy-in from the government. They need to view hepatitis C as an important problem. We are seeing some shift. Even the National AIDS Control Organization seems to be asking us more and more about hepatitis C, so there does seem to be interest. So we're going to start small, and our first step is to try and at least integrate testing, right? And so we've been able to receive some supplemental funding through Tom Quinn and the Office of AIDS Research to integrate hepatitis C testing into the sites. Of course, testing is not really anything without treatment, so we're trying to work with drug companies as much as we can to get donated drug to potentially deliver treatment in at least one site as potentially a demonstration project. So it's definitely on our minds, and we're moving in that direction. We just have a little bit longer to go. So to date, we've registered 5,000 clients across the six IDU intervention clinics. About more than 50% of them have had an HIV test, which is good. This is our primary outcome, right? So the primary outcome for the trial is having an HIV test in the prior 12 months. About 5% of those tested are being newly diagnosed as positive, and that's remained pretty stable over time. But despite the fact that we're seeing a lot of clients and a lot of testing, it seems that engagement in HIV care and treatment is less optimal than expected, right? We thought we were going to build this thing and we were going to have lots of people getting onto antiretroviral therapy, and it doesn't seem to be the case. Right, so in some cities, in particular Imphal in the Northeast, which is the green here, we see a lot of HIV positives coming to the clinic and a lot of people initiating antiretroviral therapy, right? But in the other sites, and I know it's hard to tell them apart, but in the other sites, not only are we not seeing as many HIV positives as we expected, but the ones that we are seeing aren't necessarily seeing the doctor, getting onto therapy if they need it, and just staying in care. So we've thought about this a lot, and we spent a lot of time recently thinking about this because we're trying to figure out ways to improve uptake. And so, the model that we've built, and even the models that I've been talking about in Baltimore, they're all still focused on creating this safe space, right? A center that people can come to and receive all of the services they need. But they're still asking people to come to us, right? We're still saying, basically, it's a we'll build it and you'll come model. And so maybe that's working for some people, but perhaps it's not enough for others, right? So we've essentially increased the supply of services, but perhaps there's not enough demand. And so in particular, we don't seem to necessarily be hitting the seat component, right? So we feel like there are more people out there that we're not seeing. And so this is really where I see the next 3 to 5 years of our work, kind of trying to figure out how we reach the hardest of the hard to reach. And so as a group, we've talked a lot about this, about different approaches that we might use, and these are just some of our thoughts. So the first idea is, again, we have this supply side strategy. What about complementing it with a demand side strategy, right? And creating demand specifically through incentives. Financial or non-financial, but essentially offering people an incentive to come in for care, to get on therapy, and to stay suppressed. So incentives remain controversial in HIV and in general in any field, but there is some evidence from India that suggests that they may work in this population. So this is a pilot trial that was led by Sunil and Greg, and essentially, this was done in Chennai in response to some of the earlier data I showed you where we had really high mortality and people were just not going to the government centers, right? And so what we found, in addition to the other barriers I've talked about, there was stigma, but there was also this issue of lost wages, right? So our participants are predominantly daily wage earners, right? So if they go to a government center that day, wait in line for 2 hours, they lose their wages for the day. So in large part, they weren't going because of that. So the idea here is, what if we incent for those lost wages, right? So pay a really modest amount, we're talking about $2 to $3 US, to compensate for the wages that would be lost that day. And so the incentives here were actually non-financial, right? So it was a voucher that could be redeemed for things like rice, lentils, soap, toothpaste. They could basically choose from a whole store. And they were incented to go to the government center, get on antiretroviral therapy if they were eligible, make their refill visits, and then get suppressed. And what you can see is the impact that the incentives had on that initial visit to the government center, right? So they were significantly more likely to go. We also saw downstream impacts on having multiple visits to the government center, as well as on ART refills. So something we're thinking about integrating into our ICCs. The other idea is that, we're asking people to come to us, but what if we take things to them, right? Take testing and treatment to the field. And so there have been a number of attempts to kind of do mobile HIV testing in the field through vans or through other strategies. There's probably been less of treatment in the field because it has a little bit more challenge. But the hepatitis C meds in particular, because of their short course, we think they may lend themselves to this kind of model. So we're about to start a small pilot study of 50 people in Chennai to test the feasibility of field-based directly observed therapy for hepatitis C. Now, we think directly observed therapy is really important for hep C at this point because these drugs are expensive. In India, they're cheaper than they are here, but we're not really sure what the street market value is yet, and we don't really necessarily want to find out. So we think DOT is pretty important important, especially because this is such a short course. And there's a history of DOT in India with things like tuberculosis. But the idea is that having someone come into a clinic might be too cumbersome every day, right? So perhaps we can take the treatment to them. So in this model, a peer health worker will essentially visit patients in the field every day at a place of their choosing. And it provides an opportunity not only to deliver the drug, but deliver other sorts of counseling and support. They'll still have to come to the clinic for some of their visits and routine laboratory monitoring. But again, the goal is to really minimize that and have most of the care being delivered in the field. So what we're testing here is a 12 versus 24-week regimen, and our primary outcome is treatment completion. Again, just an example of another strategy to try and address some of these challenges. And then, I've talked a lot about, well, we don't feel like we have enough people coming to our clinics or all the people that we expected to. But our baseline sample, accruing our baseline sample, had the complete opposite effect, right? Our recruitment went like gangbusters. People came in droves. We didn't expect it to go as rapidly as it did. So what did we use to do that? We used a strategy called respondent-driven sampling that a number of others in this room have used. It's a strategy that's used for surveillance of disease in hard-to-reach populations. So I want to just give an example of kind of how this worked in one of our cities so that you can see the potential reach that a strategy like this might have. So this is how this worked in the central Indian city of Kanpur. So essentially you select from the community through ethnography people that are the most connected in the population. And usually you have 6 to 10 seeds. We actually only needed 2 in many of our cities. But you bring them in and then you give them 2 coupons. And you say give these coupons to other members of your network or your friends and ask them to come and participate. And then hopefully those 2 people actually come in, redeem those coupons, and participate in the study, and this is called wave 1. Then you give those people coupons, they bring in the next wave, and you continue in this fashion until you recruit your entire sample, right, your desired sample size, which was 1,000 in our case. So aside from the beautiful picture that Allison made here, you can see here the high prevalence of HIV and hepatitis C, right? So this was Kanpur. So it was 30% prevalence of HIV, 65% prevalence of hepatitis C. But what's perhaps even more striking is this, which is that in this sample, fewer than 3% were aware of their HIV status, and no one was aware of their hepatitis C status. So again, the power of a strategy like this to just reach people, this is used for surveillance, but potentially this may be a better way to reach those who are unaware and out of care. So Sunil, who's in our group, has recently received a great score on a grant to potentially explore this in more depth as an intervention strategy, right? So to tweak it in different ways to see how we might optimize it to be used as an intervention. And then finally, if what's been happening in Baltimore has reminded us of anything, it's that context matters, right? It's about what's going on around us. And so I've talked a lot about drug use, right, and the potential negative impact that drug use has on all of these HIV and hepatitis C outcomes. But what drives drug use, right? Drug use is driven by the social context. It's driven by the neighborhoods that are around us. So this is a very oversimplified summary of dissertations of 3 doctoral students that have worked with me in Alive. But I think it gives a flavor for why this is so important. And again, these are things we know, but it's just important to remember why they're important. And this is a map, I think we've seen this a lot in recent days just because of what's happened, but it shows you the distribution of poverty in Baltimore City, right? So what's important here is the red, which are the most impoverished neighborhoods. And you can see, of course, that they're concentrated in East and West Baltimore. So where we are, of course, and then in West Baltimore. What you see layered on top of that is the Alive study visits, right? So these are over 10 years of follow-up, and of course, Alive study visits are also concentrated within these most impoverished neighborhoods. So we're not able to look at why people start injecting drugs in Alive because everyone comes in as an injection drug user, but we do spend a lot of time trying to understand why people stop. And what we find, again, not surprisingly, is that neighborhood matters. But not only just the neighborhood you're in, but the changes that happen in the neighborhood and how you move across neighborhoods. So we find that people living in the lowest poverty neighborhoods actually have a much higher likelihood of stopping, right? And then not only that, but moving from a more deprived neighborhood to a less deprived neighborhood is associated with stopping. And then finally, living in a neighborhood undergoing residential rehabilitation is associated with stopping. right? So all of these different factors driving patterns of injection drug use. So I think, the strategies that I've talked about today are really focused on healthcare settings, right? And making, again, these safe spaces for people to access healthcare. And they reduce stigma within those settings and create that safe space, but perhaps they're not doing enough for these other things around. And these are obviously the hardest issues to address. These are big challenges, but maybe there are ways that we can start thinking about even chipping away at some of this and incorporating some of this into our healthcare interventions. So with that, I go back to the question that I posed at the beginning. Are we at the beginning of the end? Should we even be talking about the beginning of the end, given that there are so many challenges? Some of this, excitement around all of this has been criticized because it's been said that maybe it's leading to over optimism, and maybe it's actually in some ways leading to complacency if people think that we're really done, both from the research community and from funders. We know there are challenges, right? I've spent the past 45 minutes talking about challenges that are sort of near and dear to me, but that's just one. I've just kind of started to scratch the surface. And, I've talked about tailored strategies and their need for drug-using populations, but there are other populations that also need these same types of strategies. Obviously, men who have sex with men, female sex workers, young women, just to name a few. And then I've talked about sort of scaling up treatment, right? Treating everyone. We need to treat everyone who's infected with HIV, everyone who's infected with hepatitis C. If we actually do that, that's a lot of people, right? Our health systems are not set up to manage that level, right? And so there's going to be need to be some creative approaches and some strengthening capacity building to actually treat this large number of individuals who need it. And then, of course, my focus is on treatment just because that's my area of interest, but we're not going to treat ourselves out of this epidemic, right? So prevention strategies absolutely need to be scaled up simultaneously, and not just behavioral prevention strategies, but some of the novel biomedical strategies as well. And if what's happening in Indiana has taught us anything, it's that this epidemic is not over in drug users, right? I think for many years we've thought that the HIV epidemic in particular is over in injection drug users in the US, at least in terms of new infections. We hear that a lot. It's not over, right? This reminds us that it's still there. And what's even more striking is the hepatitis, this pattern that we're seeing in Indiana has been occurring for years in hepatitis C. It just wasn't getting the attention in the popular press that's being given to HIV. So prevention absolutely has to be a piece of the story. And then finally, I've been reminded many times, I was reminded again today, but Andrea Cox, Stuart Ray, they always remind me that we have never eliminated or eradicated a virus without a vaccine, right? So there are many parts to this picture going forward. But hope can be a powerful motivator, right? So the idea that maybe we can, the mantras about test and treat, the beginning of the end of AIDS, the beginning of the end of hepatitis C, are powerful motivators for change, right? So they have spearheaded large campaigns to eliminate AIDS from New York and San Francisco, efforts to defeat hepatitis C in Rhode Island and New York City. And even here in Baltimore, we've at least started to have conversations about a comprehensive strategy for a C-free Baltimore. So whether we're at the beginning of the end or the end of the beginning, I'm not sure it really matters. I think it's clear that the story, a lot of the story, has yet to be written. Much work needs to be done. Thank you. So I just, before, let me do this for a second. Just indulge me for a second. So, again, as I found myself reflecting when I put together this talk, I think, a lot of us come to Baltimore and we think we're here for our 11-month MPH, and then we're out of here, And then we find ourselves, however many years later, standing up here giving Dean's lecture. And it's in large part due to the people on this slide and so many others, right? So all that's on here are the people that in some way mentored me or contributed to the work that you've just seen. But there are so many others that I've collaborated with, both here in the School of Public Health and across the street, that have really been the reason that I stay. In particular, I just want to thank one person in particular who has been my mentor for as long as I've been here, and that is Dave Thomas. So thank you for being a mentor, a collaborator, a friend, and for giving me so many opportunities at the beginning of my career, and for still today, often reminding me of that paper that I still need to write. I know I joke about that, but I kind of like it. And from Baltimore to India, where the team that we get to work with is truly remarkable. They're the kind of team that you go to and you say, so we're thinking of recruiting 27,000 people in a year. Do you think we can do that? And the response you get is, Oh yeah, of course, but we don't need 1 year, and then they go off and do it. And that's the kind of work ethic they have. But beyond that, particularly Krishnan, Sunil, and Suniti, they just make the work so much fun. They've given me a family away from Baltimore, and it's just been an incredible experience. And then finally, the staff across all of these studies, some of the staff from Alive are here today, the staff in India, the countless participants that remind us every day why we actually do this. So thank you.
Great talk. And we tape this, so if you have to use a microphone if you want to ask a question. Let me ask if there are questions. I had one. I was struck by the fairly high prevalence of fibrosis and then and some people progress very rapidly.
Yeah.
You mentioned alcohol. Are there other hepatotoxins, aflatoxin, things like that?
So I don't know about aflatoxin. I don't think there's much. I mean, we haven't measured, but I don't know that I've heard reports of aflatoxin. The drugs the drugs that are used for TB themselves are hepatotoxic. The drugs that are used for HIV, they were still using D4T up until a couple of years ago. And then I think I mentioned sort of insulin resistance. There are other drivers. And so we actually did an attributable risk calculation to see how much was driven by other things. And so while a large proportion was hep C, I think the rapid progression in particular is sort of the alcohol use, and in some part potentially the insulin resistance.
Great. Yeah. Good questions, comments?
Wow, Shruti, wonderful talk. Thank you. You pointed out, and I think everybody was struck by this success or goal reaching in India and Manipur. Mm-hmm. What's special there? Do you know?
About how they've...
Why have you been so much more successful?
So I think it has a lot to do with the state of the epidemic there and the population themselves. So as I mentioned, that is where drug use that's their problem. In Manipur you go, they'll tell you that drug use is everyone's problem here. Every house has a drug user. And they're incredibly knowledgeable. You go there and talk to them, they'll tell you about sofosbuvir, sameprovir, all the new hepatitis C drugs. And they were very involved in the early years of the HIV epidemic to kind of lobby drug companies to make HIV drugs accessible. So I think they're just more engaged and aware, and it's partially because this epidemic has existed there longer. In some of the other places, it's really new, right? And that's why, again, they haven't heard of hepatitis C, and that the HIV care access is so minimal. So it's a really different group.
People love to talk.
Thank you for your talk. It's very exciting. China is also have a large injecting drug population, and a recent systematic review that we are doing suggests that the anti-HCV prevalence is alarmingly high. And recently, the Chinese government is trying to initiate drug price negotiation with pharmaceutical companies.
Yeah.
The drug price is always a barrier. I was wondering your experience in India. Are there generic drugs available, or are there recent progressing negotiating the prices of drugs? Thank you.
So India was able to successfully negotiate a lower price than some places, clearly than the U.S. So the price of sofosbuvir compared to the original price, I don't actually know what the price now, but it was $84,000 before, but it was $900 for a course. So they did negotiate a lower price, but you have to keep in mind that that is still way too much for most people in India. And there is an agreement. There's been licensing conversations going on between the pharmaceutical companies in India and Gilead to produce generics. And they have actually come to some sort of agreement. It's taken a little while because there's been pushback. But I think Gilead's, I think they recognize that this is going to be a push, and they're trying to a little bit potentially control the process. So there is movement, and I think we hear about a couple of years before they're actually available.
So maybe I could ask a question while I'm walking back.
Yeah.
You made the point about vaccine.
Yeah.
So, where are we with Hep C vaccine, and is it a doable task?
So perhaps we should ask Stuart Ray that's sitting in the audience. No, I mean, we have a vaccine trial. There's a vaccine trial that's going on in Baltimore and San Francisco that's being led by Andrea Cox. The results aren't available yet. There are challenges. I mean, again, there are incredible challenges to a vaccine just because of the genetic diversity of hepatitis C, the fact that it doesn't elicit a neutralizing antibody response. Okay, sorry. Not a complete neutralizing antibody response. Okay. See, this is why I should not answer these questions when Stuart is in the room. Yeah.
We're still learning. I think the exciting thing about hepatitis C as a vaccine target is we don't need it to prevent infection.
Right. Persistence.
And that's, we just need it to prevent persistent infection, and that's a very different target.
Yeah.
And I think early trials in chimpanzees were looking at an unachievable goal, which was to prevent infection. The nudging the 1/3 who clear spontaneously toward a larger number could have a huge impact on the epidemic.
Yeah.
And so it's likely that we can achieve an effective vaccine. The question is going to be how effective the current target is. The one that they have, and it may be what you mean, the current vaccine that they're testing doesn't have any envelope protein in it, so it doesn't elicit any antibody response that's relevant. But the virus neutralizing antibodies are something that Justin Bailey is intensively studying, and they do exist.
Hi. I really appreciated two themes that you raised, which were the structural interventions, the need for structural interventions, and also the need for hope in the populations that you're working with. And I think two related topics, or a related topic, tying those two things together is the need for mental health support among these populations.
Yeah.
And I know you mentioned sort of peer networks and peer support existing in case management. I hope that you can speak to a little bit of the mental health support that exists and the connecting services that exist in both populations.
Yeah, no, absolutely a huge challenge because mental health comorbidity is a huge problem in both Baltimore and India, and there's also added stigma about mental health comorbidity, which complicates it. So a lot of, can't speak to the specific interventions, but the case management interventions typically involve some component of getting people into care for the other things that they need care for, and that includes mental health comorbidity and getting on treatment. In India, we do a lot of counseling. We're not actually delivering drugs that people might need, psychiatric drugs, within these clinics because we don't have that capability, but we do deliver a lot of counseling for depression and other related factors. But I absolutely agree that it's an important component of all of this.
Okay, and then, thank you. So we'll do the last question, a comment from Ken Nelson.
Yeah, it's a great talk. You mentioned a lot about the Hep C and the HIV problem in drug users. What's known about Hep C in MSM and other populations? Because, as you know, it's become an increasing problem in this country. And
you mean
MSM?
You mean in India?
Yeah, in India. What's known about Hep C among MSM in India?
Yeah, so Sunil's done some work to test the samples for Hep C in our MSM trial, and across, 6,000? We tested across 6 or 7 sites. The prevalence was negligible. It was really low, and the cases were all linked to injection, almost all, not entirely, but almost all linked to injection drug use. So we actually saw very little Hep C in southern India, but a little bit more in the couple of northern sites we had, and that's where there's a little bit more overlap of MSM and IDU. And I think part of it is potentially that the inoculum's not there. Potentially there is high risk behavior, so it could be that it's just not there, or there are different sexual practices, in India versus here, but we haven't found much.
Thank you. So it's a little after the hour, and we have a reception outside, so you get to talk in person to Shruti if you have any questions or comments. And I want to thank you for a great lecture.
Thank you.